Hi, everybody. We are just going to wait about a minute or so and let people filter in. So it'll be just a minute. Okay. It is 7, so just for sake of time, we are going to get started. I do see that the number is still going up for participants, but we have some housekeeping stuff to take care of anyway. So first of all, welcome everybody to this week's virtual meetup hosted by the Epilepsy Foundation of Wisconsin. My name is Alicia Thompson. I'm the program manager and really excited because tonight we are going to be talking about RNS, which is the responsive neurostimulation treatment. And we're going to talk about a little bit how the device works, some of the effectiveness of it, the procedure, and a lot more information from Dr. Anderson, who you will meet in just a minute. So like I said, we're just going to do some housekeeping stuff first. So all attendees on the call tonight, just know that you are muted and your videos are off, but we still encourage questions, and you can do that by using the Q&A button that is at the bottom of your screen. Feel free to ask questions throughout the presentation, or at the very end, that's fine too. We will have a slotted time for questions at the end. And regarding questions, just please know that for the sake of time, we may not be able to get to every question tonight. I'm going to type an email in the chat section as soon as I'm done talking. And you can send any questions that you think of after the fact, or if we maybe didn't have time, you can send them there. So I will type it in, but it's connect@epilepsywisconsin.org. Let me just make sure. Anything else? The other thing, as far as questions go, if we could please just keep them kind of general, again, for the sake of time for tonight. And I think that is all. Oh, the last thing I did want to say, sorry, is we are recording this. So you can expect this to be up on our website within the next few days, probably by early next week. We have a video library that we put all of the recordings in, so you can reflect back on, or you can use it as a resource and let somebody else know that it's up on our website, which is epilepsywisconsin.org. And again, I'll type that in the chat too, because I know I just said a lot of different things. So with that being said, we'll get into introductions, and then Dr. Anderson will do the presentation. So John, if you want to go ahead and start, that would be wonderful.
Sure. Hey everybody, my name is John Mirasola. I'm a colleague of Alicia's. I also work at the Epilepsy Foundation of Wisconsin. My area is client support services, social media, and communications. Alicia and I usually work together each week on this virtual meetup program that we've got going as well. Tonight, though, I am also somebody who has the RNS, something that was, I got it, and I will be talking about it a little bit more later.
Yes, thank you so much, John. Looking forward to that. All right, Jake, if you could please introduce yourself, that would be wonderful.
Yeah, you bet. Good evening. My name is Jake Griffin. I'm the therapy consultant for NeuroPace in Minnesota and Wisconsin. I just want to say very genuinely thank you for spending a part of your evening with us to learn more about responsive neurostimulation, or RNS. Tonight, we are pleased to welcome Dr. Chris Anderson, a very special guest from Froedtert Hospital in Milwaukee, where he is an associate professor in the neurology department specializing in epilepsy, with a focus for utilizing available neurostim devices. He'll be sharing with us his expert opinion on the RNS system this evening. So with that, I ask you to give your full attention to Dr. Anderson and help me virtually in welcoming him here tonight. Dr. Anderson, take it away.
Oh, thank you so much. And when we were preparing, I forgot to ask one important thing. We're scheduled for an hour. Is that true? You can just give me the thumbs up.
Yes.
Awesome. Great. All right, let's do it. So I take care of epilepsy patients in our region. And I always tell my patients, let's make sure we're on the same page. What is epilepsy? What is a seizure? And in the briefest terms, I explain how the brain has billions of little brain cells. They talk to each other with chemicals and with electrical activity. And the electrical activity of the brain is usually pretty quiet. So let's say maybe 1 out of 100 brain cells is sort of firing and talking to a neighbor, and there's an organized pattern like a computer that helps you interpret the world, function, move your limbs, hear things, form memories. A seizure is when millions of those little brain cells start discharging electrically all together in a synchronous fashion, all doing the same thing. And that causes symptoms and abnormal sensations, abnormal behavior. That part of the brain stops working when the seizure takes off. And when you have recurrent seizures, that is called epilepsy. And at least 3 million people in the United States have epilepsy. 3 million people at least have epilepsy, and about 1 million take anti-seizure medications, like most of them, but do not get their seizures under full control. Now, we know mathematically that if you try 2 seizure medications and you get up to a decent dose and you're still having seizures, the chance that medications are going to control your seizures in general is about 5% or less. So even though I don't stop at trying new medications at 2, once the patient shows that 2 medications are not going to solve their problem, I start what's called a pre-surgical workup, which means I want to know, are there other interventions that are not just medications that might help them? So that would involve things like small brain surgery, large brain surgery, devices, the vagal nerve stimulator, the Medtronic deep brain stimulator, and the NeuroPace responsive neurostimulator, which is called the RNS. And none of those are mutually exclusive. We also use the ketogenic diet, hormonal therapies. But tonight we're going to talk about the RNS and who's a good candidate. And if you're not sure, just ask. Never hurts to ask. To get an RNS, pretty much you have to come to a comprehensive epilepsy center. So that's typically in a big hospital, often an academic medical center. So once 2 medications haven't worked, you should come to an epilepsy center. Unfortunately, a lot of patients with refractory epilepsy, meaning they've been taking their medications, but they still experience seizures, only 1 in 5 actually make it to a comprehensive epilepsy center. So there are a lot of people out there who don't have access or don't know, or their main neurologist or their main doctor just hasn't referred them to the place where we only treat epilepsy. And that's too bad. We're really reaching out, trying to make sure nobody's getting left behind. Now, one of the first things I try to figure out, if I think the patient has seizures, meaning multiple seizures, epilepsy, I try to figure out, is it in group A or group B? And this is of a lot of practical importance. If they have seizures that come from one discrete part of the brain, we call those focal or partial onset seizures. Now, they can turn into big generalized seizures over a minute or 2, but they really do start in one little spot. And I need to know that because I want to know what's wrong with that spot. Was it always abnormal since the person was born? Does it show up on an MRI scan? Is it a tumor? Was it an infection? Was there bleeding? Was there head trauma? Because if the medications don't work, we might want to consider figuring out, did they really need that little part of the brain? And can we localize it? And should we take it out? And then group B are people who have so-called generalized from onset seizures. Their scans look normal, but when you record their EEG, boom, the seizure hits the entire scalp instantaneously. And on the left, you could see the EEG. So focal means that it's in one little region, and generalized means that almost instantaneously it hits the whole brain. And to keep things simple, there's not one spot that we can find, and surgery typically is not really an option for those patients. they're sort of stuck with medications and diets. And we could talk about this for a week, but I want to know, are you in group A or group B? And it's group A patients who are candidates for focal responsive neurostimulation, which is the NeuroPace device. So a comprehensive epilepsy center offers a full range of treatment options. So that includes medication, devices, brain surgery. Now we do laser ablation as well. We're going to talk about one of these options today, which is the RNS system. My phone went off, I'm sorry. Okay, I'm back. Sorry about that. So how does the RNS system work? Well, it does a bunch of things, and we call it a system because it's not just a one component piece of equipment. It actually has several components. It has electrodes that go into the brain or onto the surface of the brain, and they record brain activity just like EEG does, or even more like invasive EEG does. Sometimes we do invasive recordings to figure out exactly where the spot is where seizures come from. Well, the RNS uses invasive EEG electrodes. So they're in the head and sometimes even in the brain, recording and monitoring brain activity 24 hours a day. And we also program the device, and there's a little computer in the system. We program it to recognize what a given patient's seizure onset looks like. And that's unique to each patient. And NeuroPace has a ton of engineers and scientists monitoring patients and looking over their data so they can give us scientific advice on how we should program the RNS uniquely for that given patient. And then it responds to what it thinks is a seizure with electrical stimulation to try to scramble the seizure from propagating and kind of shut down the seizure before the patient realizes it's even started. And the device does that hundreds of times per day. And as a benefit, it records all of the events that happen on the device in a storage system in the computer. And the patient can upload all of that information to the internet, and then their doctor can look at it anywhere where they have internet access. So if the patient wakes up, maybe they've lost control of some of their bodily functions in the bed, they're sore, they have a headache, they could call me and say, I think something happened overnight, I don't feel right, did I have a seizure in my sleep? Even from my kitchen, for example, I can go to the internet, look at all the activity from their device and say, boom, at 2:37 a.m. you had a seizure, it lasted 90 seconds. You're absolutely right. I need you to come into the office so we can make some adjustments. So this is a great tool for treating, but also tracking a person's epilepsy and seeing what works and what doesn't. So what does the system look like? Hopefully you guys can see my arrow. There's a little metal housing with a computer in here, and that is laid in flush with the skull, so you don't feel any bumps or anything like that. A person like me with no hair, you might see a minor scar where the incision was made. For a person with hair, you see nothing at all. So there's no cosmetic problem with the device. And let's say I know the seizures start in this part of the brain and maybe in this part of the brain. We put the electrodes near those important little zones in the brain, and those electrodes record, and it stores it in here, and anytime it thinks a seizure starting, it delivers electrical stimulation back to that spot to try to stop the seizure. And it does a pretty good job at doing that. The patient at home has a computer with a wand, and they can hold the wand up to their scalp where the device is, and this is totally through the air, non-invasive, just kind of like a Wi-Fi connection. All that information from the computer in their head gets transferred to the internet. Now, currently, Yep, NeuroPace provides tablets that are much prettier than this. This slide's about 15 years old, but the mechanism, how it works, is the same. So this is one of my patients. I'm allowed to show you this picture because this was from a news article. He has the RNS device implanted, and this was a clinic visit. And I said, well, let me look at your seizures. How are things going? I dialed into the internet through my clinic computer, and I looked at the seizures, looked at the trends, and I said, all right, you know, there's a way we can tweak the stimulation parameters or the detection parameters, and let's make a change. And the only person who can change the settings on the device is me. So I get out my programming computer, my patient holds the wand up to his head, I change the settings on my computer, I say upload please, they change the way the computer works inside his head, and then he goes home and we see, did it make things better or did it make things worse? And he actually now lives in Florida. Now he has a neurologist down there in case there's an emergency, but I'm still his neurologist from, let's say, you know, from 1,000 to 2,000 miles away. So in terms of remote access and providing advice without having the patient in the room with you, and that's convenient in Wisconsin because this is a big state, this is a breakthrough. So we can use the device to monitor when abnormal patterns are happening, like what time of day, is it when they're sleeping? If so, we could really tailor their medication regimen to when their most abnormal active periods are during the day. Like if all the stuff happens between midnight and 8, well, there's the seizure medication that works great, but it knocks the patient out and they get very tired. Well, maybe they could just take it all before bedtime and none in the morning, and we can keep track, is that working? And then we can look at events over time. So this is like a year and a half worth of data on the horizontal axis, and we see all these bad things are happening, and then we made a programming change, which is this darker blue line, and then things get a lot better. And we can also look at cyclic patterns, like do things change every weekend? Maybe every Saturday and Sunday there's more abnormal activity because the patient goes out, has maybe too much to drink, doesn't get enough sleep. Some people, we see hormonal changes on a monthly basis. There are all kinds of rhythms in terms of seizure frequency and seizure risk that we can interpret based on the device, the data, the information provided by the device. Also, if we keep the settings the same on the device and we change a medication, we can see, did it make things look better or look worse? So this patient in early 2017 was having a lot of abnormal activity. We decided, hey, let's not change the settings on the device. Let's try adding a new medication and sees what happens. The patient was given levetiracetam, Keppra, and lo and behold, the abnormal activity drops by like 80 or 90%. So we know, you know, Keppra works to calm down the abnormal electrical activity in this given patient. Whereas if we saw this kind of high activity, we give the Keppra and nothing changes, and they say, I've become very irritable, I feel fatigued, is this even helping me? We could look from the RNS data and say, no, it doesn't look like it's really helped prevent your seizures or the abnormal electrical activity, and it's giving you side effects. Let's try something totally different. So every person has a unique seizure fingerprint, the way the seizure looks on their EEG, whether it be on the scalp or inside the brain. And they obviously have unique seizure behaviors, what they do when they feel the seizure starting, if they feel it, how they behave during a seizure, how long it is, how long the after effects are, the so-called post-ictal phase, how long does it take for them to go back to normal. So we fine-tune the device over months to years to really optimize the performance. And we do that as a team, me and my colleagues here at our hospital, but also with the scientists and our colleagues from NeuroPace. And I am not getting paid to say this, and I do not work for NeuroPace, but they have a really great team that likes to provide integrative care with us. They're willing to travel, to come to the visits, to work with the patients directly. For example, at the end of this month, I have a NeuroPace only clinic where we have 12 patients scheduled, and a few team members from NeuroPace will come and see all of those 12 patients. So the company is not out there just to make money, not at all. On the other hand, it's run by doctors and scientists who really are highly motivated to help patients. And the patients are wonderful also. We can also look at those trends and say, you know, what did make things worse? We could call the patient and say, hey, you had a big cluster of seizures. And they're, yeah, I know. What did you do? Well, I took on a new job and my boss is a jerk and I'm not getting enough sleep. And we can really see what kind of lifestyle changes make things better and what makes things worse. So intracranial monitoring, some of the folks in the group may have been through this or know about it. This is when we have a patient come into the hospital, we implant electrodes into the brain to record brain activity directly from the brain in a very precise way without all the interference of the artifacts of the world. But for the last 100 years or 1,000 years or million years, we could not do that unless the patient was in for, say, the intensive care unit with the wires exposed to the world. Well, now with the RNS, we can do invasive EEG for the rest of the patient's life with the whole system underneath the skin, tidied up. The patient can go do whatever they like, and we can monitor their brain activity and treat it. Is this a proven treatment option? Is the patient a guinea pig? Is this a scientific experiment? No, not anymore. All of the good, high quality studies to prove that it works were done over the last 20 years. The device does work. It is safe, as any kind of invasive procedure on the brain can be. It's proven to work. We have experience with 3,000 patients. We have 160 centers in the United States that can provide this type of therapy, and it is covered by insurance and covered by government insurance also. There are occasional times, just like with any intervention, medication, getting a wheelchair, you name it, when the insurance company says, no, we don't want to pay for it, then it's up to the doctor to fight with them. That really hasn't been a problem. I would never exclude this option for any patient because we're worried about insurance coverage. What are the results? At 1 year, there was a 67% reduction in the number of seizures who got the device. And at 3 years, there was an 82% reduction. So we see big changes in the amount of seizures, and it only gets better over time. Now, there are a variety of things that could be causing those improvements, like we're adjusting medications, but we're also adjusting the way the RNS detects seizures, and we're adjusting the way it treats seizures. So we can't say it's the device alone, but we know that it's one of the things that's probably helping and definitely not making things worse. 39% of the patients experienced at least one seizure-free period for more than 6 months. And a lot of my patients are really, you know, they're troopers. If you said, hey, we can make you go 6 months without a seizure, they would love that. So the device is not curative for the vast majority of patients, but to give you months at a time without a seizure, your quality of life is going to be better. The functioning of your brain is going to be better. Your memory function is going to be better. And patients always ask, is this a substitute for medications? No, absolutely not. We use it with medications. It's what we call an adjunctive therapy, but it does give us the opportunity, if the patient does well enough, to sometimes dial back, maybe take away a medication, or we could see which medications are working and which aren't, and the ones that just aren't doing anything, we can get rid of those. Less pills, less side effects. Does the RNS system improve quality of life? The answer is yes, and Kimford Metter, who's a prominent epilepsy doctor now at Stanford University, has been studying this because we know that the medications cause deterioration in quality of life. They cause fatigue, they cause memory problems, they can hurt your liver, hurt your kidneys, make your hair fall out, you could be allergic. None of those problems seem to happen with the RNS system. Cognitive function and memory problems are what bother my patients more than anything. Because even if I can get their seizures down to like 90 seconds per month, the memory problems are 24/7, 365. The nice thing is that the RNS does not make cognitive and memory function deteriorate, but for a lot of patients, it actually improves. And that's usually not the case with traditional brain surgery. There's a big risk that you could cause worsening memory dysfunction or cognitive dysfunction if you take out a part of the brain. A lot of patients know that seizures can take the life of a person, called SUDEP. The rate of SUDEP is lower for patients who have the RNS device implanted. So it would be natural, seizures are unpredictable. Patients are always worried, is today going to be the day where I have a bad one, where I get hurt, where I end up in the ER, or God forbid, I actually die. The SUDEP rate is less with the device in. So they can rest assured we're watching them and they're less likely to have a tragic outcome from their epilepsy. Who's a candidate? The rules are you have to be 18 years or older. You have to have tried 2 or more anti-seizure medications and still had seizures. You have to have focal partial onset seizures that come from 1 or 2 areas of the brain, and we have to know well where those spots are. And they have to have frequent seizures that impact their quality of life. Now, these are the rules. There are some patients who we have snuck in under the radar because we thought this is really going to help them, and we got approval either from the FDA and or their insurance company because they didn't exactly meet these criteria. So like I said, even if this slide makes you think you're not a candidate and you're interested, just ask your doctor, is there any way this is for me? But the baseline FDA approval, these are the criteria. RNS system is intended to be used in conjunction with medications. It's reversible, so there's no removal of brain tissue. If we do traditional brain surgery, take out a big piece of brain tissue, and the patient's injured or they continue to have seizures, we can't go back. If we put in the RNS system and it doesn't work, well, we always have the option of just leaving it there because it's not going to do any harm, or we have the option of taking it out, but no brain cells have been removed. How does the device work? There's a little metal tray, like I said, that holds the device, which is a computer and a recording and a transmitting and a stimulating device. And that ends up flush with the skull, so you don't feel any bumps. And let's say we know the seizures are coming from this little spot. We put some of the electrodes over that spot, and we can treat 2 sites. The procedure in the operating room can range from, let's say, 3 hours to 6 hours maybe. After the implant, the patient stays 1 to 2 nights in the hospital. But in our hospitals, typically longer, 3 or 4 days. I want to make sure the patient's really tuned up before they go home. They know how to use their computer. And if we're lucky, we capture a seizure over those first few days so I can turn on the detection settings and the stimulation parameters, and they can go home with the device in stimulation mode. Whereas if they don't have a seizure during that first hospital stay, we just, we have a wound check a week or 2 later, but we wait until the first seizure happens and then I can turn on stimulation. But sometimes that's months. And I say, hey, just enjoy it. The surgery itself has kind of shut down your seizures. Let's ride it. When you have one, you call me and I'll check. And if I agree you had one, we'll turn on stimulation. What's it like to live with the system? Stimulation is usually enabled at the first or second office visit. Patients do not feel the device working. There are some very rare exceptions, but it's even when a patient can feel it going off, it's not unpleasant. And if they did find it unpleasant, theoretically, I could just change the settings so that they didn't feel it. So unlike the VNS, where you can feel it make you hoarse in terms of your voice, patients with the RNS 99.9% of the time do not feel it going off. So they have a remote monitor, that's a laptop or a tablet, which they keep with them at home. They upload their information and transfer it to a secure website. I showed you guys that. I can review it remotely. My colleagues can. Even if I'm on vacation, I could review it, but if I forgot my laptop, I could call my office and say, hey, can you guys check on Miss Smith? How's she doing? So we get the patient's report, which is always so useful in terms of what their experience, but we also now have numerical data coming from the computer as to what's going on in the seizure network. The current model is what we call MRI conditional. Basically, that means you can get an MRI with the device. It's MRI compatible. And that was a problem because for the first 5 or 10 years of scientific study of the device, and when it was first out, it was not MRI compatible. Now it is, but your doctor has to turn the device off before you go into the scanner and turn it back on when you come back. So let's say you need a knee MRI and you're across the country and you're not near a NeuroPace trained physician, you wouldn't be able to get an MRI instantaneously. You'd have to get your device turned off near the scanner and then turn back on. I think that's the last slide. It is. And I think John's going to share some of his knowledge and experience with us. And I think we're going to have a question and answer session. So I think in terms of timing, we're doing okay. Would you agree?
Yes, thank you, Dr. Anderson. John, yeah, so we'll turn it over to John. He's just, there he is. John, so you take it away.
Okay, thank you, Alicia.
You're welcome.
Just to give everybody a little bit of a background, I have what most people know today as complex partial and simple partial seizures. And from time to time, not very often, but I do from time to time have tonic-clonic seizures. The very first seizure that I experienced was actually a tonic-clonic seizure, and it was in August of 1991. I was headed off to school, actually, and this was at Loyola in Chicago. And all the students in my program, as a Catholic school, we had to all go on a retreat the weekend before. And while we had some free time at the retreat, I went out and played volleyball with everybody and experienced a tonic-clonic seizure for the first time out of the blue. Had no idea what epilepsy was. Fell down and woke up in the emergency room. Let me just say, I'm glad it was a sand volleyball court and not a cement one. That was very nice. At that point, I was prescribed some medication. A couple of different meds did not work, but eventually I was able to find a med that did work, and I was able to move on and eventually made it to what at the time was my dream career, and that was a high school teacher. I went to about 7 or 8 years completely seizure-free, but then all of a sudden, out of the blue, seizures came back. And I was having all 3 types of seizures that I just mentioned with very, very rare tonic-clonic seizures. At that time, I had to give up driving. I had to give up any kind of climbing that I used to do or swimming. And of course, I had to give up being a teacher because the recipe for 25 teenagers in a room and 1 adult, with the 1 adult not knowing what's going on, that's a recipe for kind of a disaster in some cases. So anyway, I tried other medications, nothing seemed to work. And with the help of some family members, I got some time at the Mayo Clinic And they were able to perform some tests, including a 4-day EEG recorded session, where actually for the first time they were able to find the locations, 2 different locations in my brain where seizures were originating from, which 2 different locations obviously meant I was not a candidate for traditional brain surgery. So it was after that that I eventually learned about NeuroPace and the RNS. And I applied to be at what that time was the clinical trials. This is 2005, 2006. This is when things were still in trials. It was not approved by the FDA yet. Through some testing and some interviews and just whatever you have to do to get into a clinical trial, I was approved. And I received my RNS in February of 2008. Excuse me. The procedure, for those of you wondering about that, it was not complicated. I had to fall asleep and wake up. The neurosurgeon probably had to remember a little bit more than that. So, but in any case, the procedure was nothing horrible. I was in the hospital just a couple of nights, and I had to, because it was actually brain surgery, I did have to remain inside, really not doing too much for about 3 weeks or so. But life very quickly, with very little effort, went back to normal with a new device in my head. So today, I noticed changes right away. I would say within the first month, I noticed changes. My complex partial, simple partial seizures, both of them were cut in half. This wasn't overnight, of course, but I saw them declining week after week, and it hit a plateau at about half. To me, I was having in the beginning, I was having about 30 seizures or so a month, mixed between all 3 different kinds that I mentioned, and cut down to about 15. And this is in 2008, 2009, but throughout the time, as years went on, it got even better. And I'd say today, I'm at probably about 70 to 75,000 reduced. I have about 10 or so a month. And the tonic-clonic is extremely rare. So Dr. Anderson showed everybody how the system works. And that is precisely what I do. I take the wand right here and try and do that at least once a day. If that's too hard, at least a few times a week, so that I'm downloading all of what the RNS has picked up in terms of information, and make sure that I do that. But I also, by choice, I also keep a diary. One of the things I like to do, and anybody that gets into this and thinks that they want to do this, I would also recommend keeping your own diary as well. The Epilepsy Foundation actually has an app, for those of you who use a smartphone, but you don't have to use that. You could just use paper. But in any case, it's nice when you, whether you meet with your epileptologist twice a year, 3 times a year, 4 times a year, it's nice to go through the data that the RNS picks up and go through your diary as well and check off, seeing how much you're catching. Are you catching everything? Because myself and probably those of you listening, many of you probably don't catch all your seizures. We have a lot while we're sleeping, and the RNS is going to pick that up, most of the time, but I don't catch them all. So it's nice to be able to do that. It really boils down to cooperating with your doctor as much as possible, being as prepared as possible, because the more your neurologist or epileptologist knows, the more he or she can help you. Like Dr. Anderson also said, when the first month or so when it was working and jolting electricity, I felt it right away, but it was absolutely nothing painful at all. I just felt it. I felt a little jolt, but it didn't even make me shake or anything. I just felt a little bump in my head. But quickly, within maybe 2-3 months, it started happening to the point where I didn't even notice it. I haven't noticed it for years. The only time I would notice it is if my neurologist is making settings on there and trying out different settings. So then I might notice a little something, but again, it's nothing at all to be worried about. Once I got it, it allowed me to, even though it cut seizures in half for me, and then in some cases, to 70-75%, there were things I was able to do again. I can't do everything over again because I still do have seizures, but I am able to go on runs and walks a little bit more. I don't have to necessarily take somebody with me. I can't drive, but one of the things I was able to do was go back to school because I had to give up my teaching career. That's what I really wanted. I needed to figure out what do I want to do now. And I was in no condition having 30 seizures a month to go back to school. And so that's probably the biggest thing I was able to accomplish. I was able to go back to school and achieve a second degree. And through that and through some jobs in between, I wound up where I am today with the Epilepsy Foundation of Wisconsin and some terrific colleagues. So there you go for me.
Wonderful. Thank you. Thank you so much, John. That was really helpful. There was some questions that popped into my head for you.
Okay.
While you answered them, I was curious, Dr. Anderson talked about how patients don't really feel anything. And then you said the same thing. But you answered that. You said it didn't really felt like a bump. So I was just curious kind of what that felt like. But now we can open it up to questions. So if anybody does have any questions, you can, again, use the Q&A button at the bottom of the screen. And myself and then another staff member will take a look at those. And just a reminder, if there's something that you would prefer to ask later, if you're just more comfortable that way, that's fine. Or if you think of something after the fact, I did type in the chat section. So if you hit the chat button, I did type in our connect@epilepsywisconsin.org email, and we can get those questions to Dr. Anderson, and he can answer them and get them back, and we can get them to you. So. All right. Dr. Anderson, I guess I don't think you covered this. I have a question. So with the procedure, is there any complications, I guess, that have ever occurred, or any major, I know you said, it's, John even explained it's very simple procedure. There's, they're there for a couple of days, but is there anything, if people were, worried about, that maybe has been brought up to you before?
Yeah, there are risks. The two that we really worry about are infection and bleeding. So anytime you breach the membranes between the nervous system and the world, bacteria can get through there and can cause an infection. And when a device gets infected, it has to be removed. And the infections that we have seen with the RNS are typically just around the skin and the computer, and they don't actually go down the wires to the electrodes and infect the brain, but we don't want to take the risk of that happening. So we put the patient on antibiotics and we take the whole thing out, and the patient's fine. They're back to the way they used to be, but that's really demoralizing. I've been waiting for something new for a decade, and I went through all this work, and I went through brain surgery, and now they're telling me they have to take it out. The good news is they turn out fine, and we can always, in 6 months, go back, try it again. But it is disheartening. The issue of causing bleeding or a stroke, I've never seen that happen. But I would always tell a patient, if we're going to put electrodes deep into your brain, we're going to do our best. And I only work with great neurosurgeons who I trust. Otherwise, I wouldn't do it at all. We map out where the blood vessels are, and we try to stay away from them. But there's always the risk you could poke one and cause bleeding. I've never heard of that happening, but there's a risk, and I'm sure it has happened. Okay. The risk of infection for devices like this, I'm not going to give you a precise answer, but it's about 5% or less, but that's pretty high. So that means like 1 out of 20 patients will get an infected device, and probably half of those will have to get it ripped out or removed. But those are the main risks. In terms of hurting cognition, hurting their memory function, weakness on one side of the body. Am I gonna, be a vegetable, so to speak, for lack of a better term? That's what a lot of people use, meaning I just can't function anymore. That kind of stuff just doesn't happen.
Wonderful. Thank you for answering that. So we have some more questions. Does the device have a battery and need to be replaced like the VNS does?
It sure does. And the first model that was FDA approved had a battery life of approximately 3 years.
Wow.
And at the end of that period, the surgeon would go back, open up the skin incision, and I'm not sure if you guys can see me, but it would be about, 2 or 3 inches, and then open it up, open the skin, and then take out just the computer part, not the electrodes in the brain, and replace it with one that has a new battery. Now, the current model, the battery lasts on average 8 years. So that's even better. That procedure, you probably would not have to spend the night in the hospital because it's basically just an incision, a couple sutures, and some steri strips, and you go home. So 8 years is pretty good. I'm sure the next model will be twice as long, who knows. So I don't think it's a big deal. One day out of your life every 8 years to get rid of 50 or 75% of your seizures or more, I think it's worth it.
Yeah. Jake, I'm sorry. Did you want to add anything to that question?
No, that was perfect.
Okay.
Thank you.
Thank you.
Yeah, 8 years is what we expect on average. Yep, just as Dr. Anderson said.
But it could
With
be
the
a
new
little bit shorter or a little bit longer, depending on how much the device is going off.
Right.
So
Absolutely. That's a perfect answer. Yep.
Yeah, if I set it to be really sensitive and go off 2,000 times a day, it's going to take that 8 years down to like 7 or 6. Or if the patient does so wonderfully that the device is quiet all day, it'll be 9 or 10 or 11 years.
Wow. That's a long time. Another question. My son has a VNS already. Can he have both, or would the other VNS need to be removed?
You can have both, and that's very common. In the big clinical trial, a big proportion of the patients had a VNS already. So you can have a VNS and an RNS. That is increasingly common. You could even get an RNS, and if you weren't seizure-free, you could go get a VNS later. And there are some pretty radical combinations of other stimulators with the RNS that are not commonly done. But the simple answer is yes, you can have 2 devices. And the Medtronic DBS, you can get that with the VNS, and the NeuroPace RNS, you can get that with the VNS, and it's very common, and they don't interfere with each other at all.
Okay. Jake, anything for that one?
No, that's great. Absolutely.
Okay. Thank you. Just want to check. Let me see. So this question says, since this is on a computer, what safeguards are in place to prevent hacking into the system?
Jake, maybe you want to answer that, because I'm sure that you guys have a lot of fancy technology because there's a database which is centralized for all the patients, which NeuroPace has access to. But then, like in Milwaukee at Freighter, have access only to my patients. And
right.
It's pretty rigorous, like what the ID is and the password and who I'm allowed to see. So I can't talk about the security of the system. I can reassure you that if other neurologists can't figure out what all this information means, a hacker is not going to be able to figure it out either, nor would they even be interested. In terms of hacking in to change the settings on your device, I don't think that's possible because they would have to have my programmer, they would have to be in my clinic with my patient, with my computer up to their head to mess with what I'm doing as I interact with the device. So I don't even think that's really possible. But in terms of the data that's on the internet getting uploaded and from the server, only NeuroPace could answer that question, but it's not something I worry about.
I agree. Not something to worry about. The ecosystem is completely closed and safeguarded. So We can certainly supply a more in-depth answer to that from the VP that's in charge of that out in Mountain View, California, where our headquarters is. But like Dr. Anderson said, it's just not something that should be worried about.
Wonderful. Thank you. I'm just going to look at the Q&A again. Let me just see if that one was answered. Okay. If anybody else has any questions, feel free to submit them. We can just wait a few seconds. I don't see anything. It looks like.
I'm going to make a comment.
Yeah, absolutely.
You can get this device implanted and set up at one medical center and still get treated at another. So I had a UW patient who's geographically closer to us, so UW said, hey, just go over to Freighter. They know what they're doing. I have patients who are traveling with the device. They can get it checked at any big hospital. I'm sure every state of the 50 states has a center or close. Or even if you live in a really distant rural area, you could come to the big medical center, get the device implanted, and let's say every 3 months, make the big trip to see your neuropace doctor, but still have your local epilepsy doctor or local neurologist take care of everything else. And they could always, pick up the bat phone and call me and say, we got an RNS issue, and I would see that patient fast. So you don't have to live in Milwaukee or Madison if you're a Wisconsinite to get this.
Wonderful.
I did see another question that popped up, Dr. Anderson. Alicia, maybe you saw it, but
go ahead.
Do you typically turn off the VNS before RNS gets implanted? There was a question about that.
No, I just leave the thing running. If the surgeon has some concern that current coming off the VNS would be a problem, or that currents in the operating room could sort of scramble the VNS and make its settings sort of go haywire, we would turn it off, but I don't think we have a rule about that.
Okay.
So even if we did, the patient would be under anesthesia, they would be unlikely to seize, and we would just turn the VNS on, boom, the second they hit the recovery room. So if we decided for some sort of safety concern, we wanted to turn it off, it would be just for the anesthesia phase.
Pre-op, post-op type of thing.
At the most.
Yep. Thank you.
Thanks, Jake. Thank you.
Yeah.
Let's see. We have a question. If somebody is getting this device, does hair have to be shaved off for the surgery? And I think you might have touched on that earlier.
I'm a little biased, but yeah, it's instead of shaving down to the scalp, the hair is clipped so that it's short. And no, it's not the whole head. It's just sort of the region where the device and the computer is going to go. So let's say you had nice, beautiful long hair, you could just kind of comb it over that spot for a month or two until the hair grows back. And given what's popular in terms of hairstyles these days, the sky's the limit. But yeah, you would lose some hair temporarily.
Yeah, thank you. How many complex epilepsy centers are there in Wisconsin? I know that I think Jake, we had this question earlier. Is there a link that we can share for that? Yeah,
it's just right on neuropace.com, find a center. So it's right at the top, just find a center. And that way, if anybody's on the chat or listens to this later and they're in a different state, they can just go to neuropace.com. And then right there at the top bar, you'll see find a center. And then you just type in your zip code and up it comes. So hope that's helpful.
Yes, thank you very much. Let's see, I think we have one more. Okay, so this is, can the RNS be a replacement for the VNS? Can the VNS be removed if I get the RNS? We have another question on that.
The answer is, in terms of replacement, The answer is yes, but it's not a one-to-one replacement because it's comparing apples to oranges. But either device can be removed, either device can be left in and functioning. And if one of them dies, you can just leave it there. With VNS, if the patient says it didn't do anything, I say just leave it there, let it die. If you really have a reason to get it removed or it's a cosmetic problem, we'll pull it out. Some patients say, I just want this thing out, and we take it out. I usually say, unless you have a medical reason to remove a device, just let it sit there. It's not going to do any harm. It's probably safer to leave it in than make another wound and risk a wound infection and have anesthesia. Having a dead VNS in your chest carries basically no medical risk at all, unless you have a rotator cuff tear, let's say, theoretically, and you need a scan of your shoulder and the VNS is getting in the way. That would be the kind of scenario where you would want to remove it. And once with either of these devices, if you remove it, you go back to your normal self the way you were before the implantation. Some people say that with the VNS coil, you can't take the coil off once it's on. That's actually not true. We have not only taken off the coil successfully, but we have replaced it. So both of these devices are 100% removable.
Great, thank you, Dr. Anderson. I don't see any other questions. We do have a few minutes left, but again, if anybody does have questions, please use that connect@epilepsywisconsin.org email that I typed in the chat. So if you want to write that down. I don't see any other questions.
I'm going to make one comment.
Yep, go ahead, Dr. Anderson.
Always ask, because even if you think, oh, that's not for me, just ask. Is this for me? What's new? What's available? And two, I always try to hook up families that are considering something to other families that have been through it. And that goes for big brain surgeries, devices, VNS. If someone's like, I don't know anything about this, I say, all right, this person's done it. They're willing to share their experience with you. So has this person. I'm not going to get in the way, but they gave me permission for you to call them. Call them, you guys become best friends. And you can say bad things about me or nice things or whatever, just be honest. And don't get all your information off the internet. Some of it's good, some of it's not. But pretty much epilepsy patients are going to be straight up. They've been through it. They're going through something similar to what you are. They want to help. So reach out. There's no stupid question.
Right. Yes, it's always nice to have somebody else to talk to. And John, Jake, do you guys have anything else to add before we end tonight?
Not for me.
No, I just want to say, thank you to the Epilepsy Foundation. Thank you, Dr. Anderson, and thank you, John, for getting on tonight. We're very grateful.
Yes.
And I can't see the group, but thanks for being here.
Yeah, thank you all so much, Dr. Anderson, John, Jake. Thank you and everybody for taking time tonight. We appreciate it. Again, this recording will be up within the next couple of days by Monday or Tuesday next week up on our website. So you can find it there and refer people to it if anybody has any questions. But with that, thank you again and have a good night, everybody.
Take care.
Bye-bye.